This video will cover the lower limb. So we're going to start by going through a review of the proximal femur. So you can see the head of the femur here, as well as the neck, and then the greater trochanter out here laterally, and the lesser trochanter you can sort of make out here on the posterior lateral aspect of the proximal femur. And then remember that anteriorly there's also the intertrochanteric line, posteriorly there's the intertrochanteric crest. Here we have a diagram, an artist rendering of these structures again, so you can see the head of the femur sitting within the acetabulum of the hip, and then we can see the intertrochanteric line, greater trochanter. Remember then the lesser trochanter would be right about here as well. So now looking at an AP radiograph, you can appreciate these structures on here with the head of the femur, the neck, the greater trochanter, lesser trochanter, and the intertrochanteric line, again looking anteriorly. Now we have a left lateral hip view of the hip. So here now we can see the intertrochanteric crest. Again, this is going to be because we're looking at the posterior aspect here of the bone. We have the lesser trochanter, the greater trochanter, and then the head of the femur. All right, so looking at how to evaluate the hip, most of the time we're looking for either a traumatic injury or a number of different types of pathology, such as avascular necrosis, aseptic necrosis, osteoarthritis, etc. And so when you're evaluating the hip, especially for trauma, you want to be looking at usually two views, an AP view as well as a frog leg view. And then in terms of the specific places that you want to be looking for widening of the joint space. So it's going to be within where the head of the hip, the head of the femur is sitting within the acetabulum. You see widening of that joint space. That's indicative of a potential dislocation. And so when there is a dislocation present, it can be either an anterior or a posterior dislocation. And so with a posterior dislocation, the femoral head is going to be located up and out. So here in this image, you can see the patient's left. There's evidence of a posterior dislocation of the femoral head. So you can see where the acetabulum is right down here, and then the head of the femur is up and out of the joint. So that indicates a posterior dislocation. On the patient's right here, you can see that they have a bilateral dislocation in this case, and so anterior dislocation results in a down and in location of the femoral head relative to the acetabulum. You also want to evaluate the femoral neck and the intertrochanteric crest and line for any evidence of fracture there. And then you want to look at the pelvis as well, as specifically the acetabulum, to assess for a fracture, which it does appear that there's a fracture here in this patient located right here. Just an FYI in terms of the locations of fractures of the proximal femur. So affecting the head and neck, you can have a subcapital fracture, which is going to be located just right at the junction between the neck and the head of the femur. A transcervical is right across the midpoint of the neck, and then another one that can occur right at the base of the neck. The other possibility there's two other possibilities, which would be the intertrochanteric fracture or a subtrochanteric fracture, which is right at the proximal part of the shaft of the femur. So here we have an example of an intertrochanteric fracture, which you can see going across the intertrochanteric line in this individual. And then here's a femoral neck fracture. So this is at the base of the neck. So you can clearly see that coming across right there at the base of the femoral neck. This is an example of a dynamic compression screw that's been inserted into the femur in order to treat a femoral fracture. So you can see how there's several screws down here that are anchoring the device in place along the shaft of the femur, and then you can see how the other part of the device has been screwed into the head of the femur in order to provide that stability to the hip joint, or to the proximal femur. This is an example of Knowles hip pins. So this is a similar approach where these are effectively screws, but we call them pins, or kind of like nails, and you'll put them right into in this case, the head and neck of the femur in order to help reinforce it post fracture. Recall from gross anatomy that there's two primary arteries supplying blood to the head of the femur. Number one, the medial femoral circumflex artery is going to be the dominant supply to the femoral head, so it's going to be supplying virtually all of the head, with the exception of the location of the ligament of the head of the femur, which is right around the fovea of the head, and that's going to be supplied by a branch off the obturator artery. So compromise of either one of these two vessels is going to lead to avascular necrosis of the head of the femur. And so here we have an example of that. You can see on the patient's left hip here an example of avascular necrosis. And so this is a very common site. Actually, it's more common than any other site in the body, likely due to the combination of precarious blood supply and then the high load on the joint when standing. So when even a small amount of the blood supply to it is compromised, it's going to lead to pretty significant avascular necrosis of the head of the femur. And so here you can see a zoomed in view of that necrotic tissue. Here we have a coronal MRI of a patient, and once again you can see where those black arrows are pointing out a necrosis of the head of the femur. But in this case, it's not an avascular necrosis. Instead, now we're looking at an aseptic necrosis. So that's due to an infection that's led to the necrotic breakdown of the head of the femur. So another major issue that frequently affects people in their hip joint is osteoarthritis, or OA, also known as degenerative joint disease. But OA is probably the more common way of referring to it. And so one of the hallmarks of OA is narrowing of the joint space. So if you compare the right and left sides on this patient, you'll note you can see a nice joint space here on the left. On the patient's right, on your left, and then on the patient's left now on your right, you can see this narrowed joint space as a result of the degenerative joint disease taking place here. You also oftentimes see evidence of osteophytes or bone spurs, which you can see here and here. And so one of the major ways that we treat osteoarthritis of the hip is total hip replacement. So we just call this a total hip, or a total hip arthroplasty. And so effectively the way that we do this is, you can see this is called the acetabular cup right here, which is placed within the acetabulum, and then there's a sort of a ball and a ball that sits within that cup that allows for the hip to be able to pivot in virtually any angle. And then here's the stem of the implant, which has the ball on the end of it, and so that goes into the proximal part of the femur, and then actually is placed within the medullary cavity, or the marrow cavity of the bone. So you can see how that mimics basically the head and neck of the femur in a non-revised hip. And so you can actually see here where the proximal part of the head of the femur is actually removed, or sorry, the head and neck of the femur is removed in the surgery and fully replaced by this part of the joint implant. All right, so take a moment to look at this image for a moment and see if you can identify what the arrows are pointing at here. And so these are actually not fractures, but instead normal apophyses. So these are going to be apophyses related to the greater trochanter on the left, and then on the right image you can see this is a normal apophysis in a child. And both of these are going to be from children, and so in pediatric patients. And so the one on the right is showing you a normal apophysis of the lesser trochanter. So now looking at the more distal part of the femur, remember that we have a long shaft. The femur is the strongest bone in the body. It's also one of the longest, and so it does take a tremendous amount of force to fracture the hip, and the proximal part of the hip is the most at risk due to the angulation of it, but the shaft is also certainly at risk of fracture, and so we'll look at that here momentarily. Distally, remember that we have the medial and lateral epicondyles, and below that we have the medial and lateral condyles, which sit on top of the tibial plateau, and those are both going to be covered over by articular cartilage. So you also have potential osteoarthritic change that can occur along the medial and lateral condyles in older individuals. This is an example of a displaced oblique or a spiral fracture of the femur. So you can see the displacement clearly where the two ends of the fracture are no longer aligned with each other. So that's likely going to require an ORIF procedure in order to approximate those ends and allow the bone to be able to heal well.